Hello, and thank you for joining us for episode 11 of Mazars Healthcare Digest. My name is Val Tuerk, and I'm a senior consultant in the Healthcare Consulting Division. And I'm here with Justin Frazer, who's a director in the Healthcare Consulting Division. Today, we're going to discuss coverage for support services for people with intellectual and developmental disabilities. So Justin, how do most individuals with intellectual or developmental disabilities get their support services?
Really good question, Val. So for most individuals with intellectual and developmental disabilities, they get their service through Medicaid. So Medicaid is the primary payer of long-term services and support, or LTSS, for individuals with intellectual and developmentally disabled. And, interesting enough, this covers half of all of the Medicaid spending. Because these services without Medicaid are either unavailable or unaffordable through Medicare and private insurance. Interesting enough, the per person spending for people with IDD is higher than those for other populations due to the intensity and ongoing need for supports across an individual's life. Here's an interesting statistic. In 2018, 1915 waiver C, which is long-term supports and services, waiver spending was about $46,300 per beneficiary. In 2019, Medicaid spending for a full benefit, enrollee without ID is $22,233. So you can see, it's twice as much for individuals with IDD. State Medicaid programs are required to cover these long-term support services in nursing homes and intermediate care facilities for individuals with intellectual disabilities, whereas most home and community-based services, which are clearly the better one because it's being less institutionalized, are optional, which results in different states having different home and community-based eligibility benefits and delivery systems.
Can you just describe some of the different services that people with intellectual and developmental disabilities receive?
Sure. So like I alluded to on the last slide, IDD services are increasingly delivered in home and community settings and less in institutional settings. And most states and federal laws are moving away from institutionalizing individuals with intellectual and developmental disabilities. And you can see on this chart here on the right about how spending for institutional is going down and state spending for home and community-based settings is going up. And this is not a coincidence. There are some federal rules which is causing this change in healthcare delivery. First, there's the landmark Olmstead decision, which is part of the American with Disabilities Act, which requires states to provide services to individuals with disabilities in the most integrated setting appropriate to their needs. And then they have the two waivers, which is first the 1915 C, which allows states to apply for waivers to provide home and community-based settings to individuals. And then the 1950 I waiver, which states can provide home and community-based services to individuals who may not require institutional level of care. So for the first time since 2013, home and community-based services counted for 55% of total Medicaid long-term spending in 2017.
Wow, that's a large percentage. Do most states have long-term support services as part of their Medicaid managed care delivery?
20 states include IDD population in their managed care programs. Most states do have it. And as you can see from this chart, the states that are here in blue are states that include IDD in their managed care program. The states are in green, the state has managed care, but most likely the services for the intellectual and developmentally disabled are still going to be part of the fee-for-service. And these remaining outlier states doesn't have a Medicaid managed care program. So here's how the delivery varies in different states. In some states, it's fee for service. So individuals with IDD are excluded entirely from Medicaid managed care and receive all their services via fee for service. Where in other states, states enroll individuals with intellectual and developmentally disabled in managed care and may enroll them in different types of managed care plans that cover the range of services. And some of these plans are standard plans, where individuals with IDD are enrolled into the same plans as other Medicaid enrollees, or specialty plans. And these are plans that the state has, Medicaid plans specifically serving individuals with intellectual and developmental disabilities. The scope of the services covered by managed care plans may receive all services via comprehensive plan, or if it's a specialty plan, may receive some services fee for service and some services through Medicaid managed care.
Well, for some of the states that are considering carving in these benefits, what are some of the considerations for the Medicaid MCOs?
It's a great question. Really good question. There are four considerations. There's the member-facing considerations, the network provider-facing considerations, amending internal operations, and regulatory and clinical requirements. It's a challenge. It's a challenge, Val, because what is happening here is you have a Medicaid managed care plan that is traditionally responsible for covering an individual's healthcare and behavioral health needs. Whereas you can see with the IDD population, it's more about support services. So historically, Medicaid managed care plans, or just HMOs or MCOs in general, don't have the resources to provide support and services to this population. So it really is a challenge, especially if a state is now saying part of your core competency managed care plan is to provide support and services. So just going into the specific considerations, first there's the network and provider consideration. Most of the services for the IDD are non-for-profit, mission-driven providers. Many of these providers are not familiar with managed care principles such as authorizations, approvals, denials, appeals, and grievances. There's a general sense of mistrust among the provider community of managed care. It's going to likely require enhanced provider relations or network management support. Then there's the fee schedules. There's nuanced state and regional reimbursement for services. So how will local MCOs manage provider rates? Will there be a rate protection? And then there's the contracting dynamics. What are the network requirements? Is it any willing provider who serves the IDD population will get a contract to be a network? Or will the managed care organization force the IDD providers to form IPAs? Not known. Then there's the negotiations, where none of these IDD providers have ever negotiated with a managed care plan, and now they're supposed to negotiate a rate for themselves and a living wage so that they can support this population. For the member considerations, there's a unique customer service needs for a compromised population. There's a need for alternative to telephonic-based customer service. What's happening now is studies have shown that there's potential for longer customer service calls and therefore greater operational staffing costs to the MCO. And there's also, because this is a new benefit and learning this new benefit, there's a greater potential for appeals, particularly during the Carve-in transition period. For the operations and systems of the MCO, it's a unique benefit with a unique system configuration. There's the integration of the waivers and other benefits into the managed care environment, developing value-based contracts and metrics for services that do not have conventional outcomes or improvement measures, and then training aids and guides for staff to support servicing a compromised population. And then finally, there's the regulatory and clinical considerations. integrating multiple state, federal, and local regulatory departments with often conflicting requirements. There's going to be the whole set of reporting requirements for this population. There's a unique and limited IDD care management skill set. There's a lack of CPGs for authorization and services, an adoption of a standardized assessment tool, integrating IDD long-term support services within medical management, and then balancing the member choice and the need for the least restrictive setting for the provision of care with basic managed care principles, which at times just is a conflict in and of itself.
Wow, there are a lot of considerations. Thank you, Justin. This has been very informative. If anyone would like more information, you have our contact information right there, so please don't hesitate to contact, and thank you very much.
Thank you, Val.